You're listening to Innovators, the podcast from Harris Search Associates, where we speak with global leaders in education, research, engineering, and the health sciences, and ask them to share lessons learned as they continue to advance the frontiers of innovation and discovery. Today's podcast will be led by Rick Skinner, Senior Consultant.
Today, our guest is Dr. Ed Funai. Dr. Funai has held executive positions at Ohio State and the University of South Florida, as well as serving as professor of obstetrics, gynecology, and reproductive sciences, associate chair, chief, and associate chief of maternal fetal medicine at Yale University and at New York University, where he started his academic career. He earned a Master of Arts from Yale, his MD from New York Medical College, and a Bachelor of Arts from Notre Dame. He was awarded a fellowship in maternal fetal medicine at NYU and completed a residency at Lenox Hill Hospital in New York City. The time required to become a doctor, join a medical school's faculty, earn tenure and promotion, become a department chair, and then be appointed dean is a substantially long one, 20 years at least. In most cases, there's precious little time for someone in academic medicine to acquire management skills or business acumen, both of which increasingly are needed to oversee a medical school. As a result, most deans of medicine learn those skills on the job. How does that pattern stand up to what is required of medical schools and their deans these days?
I think when you think about the whole process to get into medical school and to excel in medical school, what we're really rewarded for as physicians is being solo achievers. The training in medicine and the level of accomplishment that it takes to get into medical school is not a team sport. It's based on individual achievement. So a lot of effort is focused, obviously, on getting good grades, mastering the content, and then all of a sudden you're out there on the floors, either as a resident or when you graduate your residency as an attending, working in a very complex system that really isn't about individual achievement anymore. The only way to deliver quality healthcare is as a team. And when I say as a team, I'm talking about other providers learning to work well with nurses, hospital administrators, physician's assistants, medical assistants, respiratory therapists, the list goes on and on. But it takes a very complicated, well-coordinated team to deliver great care. And if anything, the physician is more of a conductor of an orchestra rather than the featured player in today's healthcare setting. Right out of the box, you get a sense that docs are not necessarily prepared with management tools necessarily to work in that environment because they've always been rewarded for their own individual success. Then when you talk about academic medicine or moving into leadership positions, a lot of chairs traditionally have ascended to their tenured positions and their leadership positions by being great scholars. And that's very important in academic medicine. That involves writing grants, getting grants, publishing a lot of papers, leading research endeavors, and in many cases, running a basic science laboratory. But again, unless you do it at a very grand scale, which is rare, these are skills that are, again, focused on individual achievement. Nowhere is it required in any of your training, including my own, that you have any classes in management, any classes in basic accounting, any classes in finance of any sort. So as you ascend these roles, a lot of it is on-the-job training, without question. And that is very dependent on your own innate level of curiosity and the time that you have to devote to learn on the job. That was something I had to do my whole career, learn on the job, although I found it quite fun. But did I have formal training in things like accounting and finance? Absolutely not. But just like learning to practice medicine was learning a new language, when you're in a leadership role and you're working with hospital administrators and finance people, I think it's incumbent upon you to get and learn their language and speak their language and understand the terms that are vital to them. That's where I learned things about what a balance sheet is and a profit loss statement and statement of cash flows. These were things that I had never heard of until I was actually well into my career in medicine. The problem I think that we're really faced with, though, is after so many years to reach the tenured level or the chair level based on being rewarded for your individual achievement, I think the hallmark of great leadership is not about it, not having it be about you anymore. So take being a chair for an example. What I've always counseled people that were contemplating going into that role or taking a job like that is, are you ready to put your own career as secondary? Because now that you're contemplating being a chair, it's not about you giving that oral presentation at a national meeting or about you being the principal investigator on a grant. It's about you nurturing and bringing forward your faculty and your staff to that level of success. And it's about being a little bit more in the shadows. And your success, the way you're graded, is very different than the way it has been your whole career. It's not based on what you do. It's based on what you help your people do. It's not something that comes naturally to physicians, not because of who they are or any defect in character, but how they've been conditioned to get to where they are today.
Let me follow up on that. Just in the course of our discussion, you've used the word spiritual. You've talked about a physician's heart. And then as you began describing what it takes to move up into administrative roles in academic medicine, you sort of suggest that the people who enter medicine, by and large, are motivated by a deep desire to care for people. How much of that gets shed in the process of moving through these ranks?
More than many of us, frankly, would care to admit. When I see medical students and interact with medical students, they are as altruistic as you can imagine, especially this generation of millennials. I think what they end up, though, is being run through a sausage grinder of a healthcare system that really is not terribly functional and hasn't necessarily prepared them for the more mundane practicalities to go out and make a living. I often support white coat programs at medical schools that I'm in, and that is, you make a donation and you actually sponsor medical students' first white coat. And one of the things I write to them, and a lot of it is tongue in cheek, but I tell them one of their first obligations is to buy a really comfortable pair of shoes. And that may seem like strange advice, but it's a job where you're on your feet a long time. You really can be exhausted at the end of the day. Your feet are the first thing that go. And what I'm trying to impart to them is that you have to learn to take care of yourself in order to take good care of others. The problem that a lot of these young altruistic people find when they're finally out in the world and they're finally no longer in training is that we haven't necessarily given them all those other skills that we've talked about. Some of the most basic skills is how to make a living. And what I mean by that is take professional coding. When you encounter a patient, you need to put in some codes, ICD-10 codes as far as diagnosis, procedure codes, or evaluation and management codes. I've yet to be anywhere where there's substantial training either in medical school or in residency about how to do that and how to do that properly. You're sort of thrown into the deep end of the pool when you're attending, and the assumption is with a tiny bit of orientation that you're going to be smart enough to just figure it out, even though your livelihood depends on it. So this creates a whole other set of stressors. That and the demands in terms of hours and family life to even become a physician. I'm afraid that it is a bit still too much like a military boot camp where we take wonderful people and harden them quite a bit so that they are out there and sometimes we frankly beat the goodness out of them a little bit. And it's not just true in the physician world. There's an old adage among the nursing world that nurses eat their young. Same thing. They take a lot of times these young, fresh-faced grads that just want to go out and help patients at the bedside, and their own politics and their own hierarchy sucks the altruism out of people, unfortunately, too early in their careers. It's something that we truly need to be cognizant of.
Some years back, it's probably 20, 30 years, there was a public policy analyst who somewhat flippantly argued that the problem of limited access of rural patients to quality health care was not that the doctors weren't practicing in small towns or areas of low density population. Instead, he suggested we ought to be paying residents of those areas, and residents are not the residents of physicians, not physicians, to locate to more urban environments where the doctors really are. Now, there's a bit of flippancy to that, but how is it possible, given all that you've just described just today, how can you maintain, or better still, improve access to quality health care in the face of, to begin with, a shortage of physicians, and secondly, the primary care is available, and practice, and as well as the desire on the part of physicians to practice geriatric and family medicine, which in the end don't get reimbursed very well. Leaving out the satire, what's the answer to us improving, if we can, access, and at the same time reorienting those who want to move into healthcare and medicine to providing service to populations that are not necessarily urban or even suburban?
It's a great question. It's a very timely one. As a matter of fact, there was an article just the past few days in the Wall Street Journal about how a lot of working poor have moved to the suburbs because the cost of living is somewhat easier or better, only to find themselves in healthcare deserts. Really hard to find care at all, primary care, especially if they're on Medicaid. Let me take the sort of satirical statement in two parts, because I think there's some truth in it, and I think there's also some unrealistic aspects of it. Let's start actually not so much with the doctors, but with hospitals. It's always been a head scratcher for me that a lot of communities virtually demand that there be a hospital in their own backyard, that nobody wants to drive more than 5 or 10 miles to get inpatient hospital care. The problem with that is twofold, especially in more rural communities. Number one, in terms of quality, we know in healthcare, especially when you're doing procedures, surgeries, that sort of thing, that experience and volume matters. So the more you do of something, especially when it's technical, the better you are at it. So I've always been uncomfortable with some very low volume hospitals, not necessarily rural access hospitals, they serve a different function, but low volume hospitals taking on some higher tech, more complicated procedures, because frankly, a lot of times they're just not doing enough of it to be good at it. The other problem with everybody having a hospital in their own backyard is cost. Right now, the way hospitals and physicians are paid is, again, you're paid for what you do, and hospitals are paid for filling their beds. So the more beds that you have in a region, the more pressure there is. I would love to see, although I don't think it's going to happen in a free market system, and there are a lot of great things to be said of free markets, where we have much more centralization, where the higher tech things, especially the procedurally focused things, are focused in hospitals and regions that are centers of excellence. And I don't think it's so tragic for somebody to have to drive an hour and a half or 2 hours if they're going to be in the hospital for a few days to go someplace that does a lot of a certain procedure and is really good at it. So that's the hospital piece. The physician piece, I don't agree with the satire at all. There, I think, without question, the access to ambulatory care, especially primary care, it works best when it's out in the community. And part of why that works best is because, again, the problems that we have in healthcare and in the system, it's really not about health. It's about fixing, focused more on preventive care and achieving healthy outcomes rather than just fixing people when they're broken. But for that to work, I need to go back to some of the comments I made about what it takes and the cost involved for it to for physicians to become who they are. I do think that we need a more organized or national program where those in more rural areas where there's a need basically get their medical education for free with some requirements for service.
Mm-hmm.
Now, there are some elements of this that some medical schools and regions have tried to put together. There's the National Health Service that is moved in that direction, but not as far as we really need to go. And some of this, I'm speaking with a recollection of some good friends in medical school, a few that wanted to be pediatricians, actually, but I happened to go to one of the most expensive private medical schools in the country at the time. And some of these folks would be graduating, and this is in the mid-1990s, with debt payments that would equate to about $6,000 a month in debt service.
Mike.
Now, when you think about that and think about the fact that the average pediatrician probably only makes $130,000 a year,
Mm-hmm.
what they'd be left with for paying their medical school and college loans is a functional salary that's not all that different than unskilled labor.
Yeah.
So until we make choices more financially attractive and less burdensome, or even the playing field in how doctors get paid, frankly, it's not a matter of greed, which I think is a misconception in the American public's mind. A lot of people had to borrow so much to go into medicine and get where they are that, frankly, for what internists and pediatricians make, they can't afford to become those docs and then go out in the world and take care of the people that need it most. The economics just don't work.
Listening to you talk, Dr. Funai, it leads me to think that in your career, as young as you are, quite honestly, you've had some remarkable vantage points from which to view the delivery of care, the business of healthcare, education and training that goes on to preparing physicians, the extraordinary importance of technology in all aspects of medicine and health, as well as some rapid and not always permanent changes in the role of the federal government. So if you were advising a young person contemplating a career starting as a physician, but perhaps aspiring, even at an early age, to hold an executive position from which she could or he could exercise some substantial influence on medicine and healthcare, what advice would you give her or him?
I've been faced with counseling people in exactly that level of aspiration. If I were to be engaged to speak with somebody early enough in their career, and let's say when they're entering college thinking about medicine, my advice as far as gaining an education, if they really want to be in leadership, is to only take the absolute basic requirements, scientific requirements like organic chemistry and calculus and things like biology. Only take the basics. Spend your undergraduate education learning about business, learning about management, and especially learning about leadership. Medical education requirements have evolved over the years, fortunately, where there's not an expectation necessarily that you're a biology major or a pre-med major or a science major to get into medical school. You just have to take the prerequisites. So get as diverse an education as you possibly can as an undergrad. Part of what I think makes an effective leader in medicine, be it academic medicine or others, is having spent enough time practicing within the system to understand its limitations, to really have recollections and experiences about how frustrating the system could be for patients, for physicians, for nurses. It allows you to really tell a much better story, advocate a lot more strongly for better care, and do it with real world examples. So to boil it all down, my advice to people that say, I want to go into a leadership role in medicine is I tell them at least spend the first 5 years of your career, once you graduate from residency, being the best doctor that you possibly could be. And, if opportunities present itself on some projects or make a name or show your aptitude, fine, but don't seek out leadership. Establish yourself as the best physician that you possibly could be and gain the respect of your peers. Because if you don't have the respect of your peers as a practitioner, you're not going to have the respect of your peers as a leader.
Let me reluctantly close with our final question, and it's about technology. in a very provocative book, the father and son team, Richard and Daniel Susskind, talked about the changes that we're going to see in the professions, the traditional professions, law and medicine and the like. And they quote Eric Topol, who's a cardiologist and a professor of genomics. And he writes, "We are embarking upon a time when each individual will have their own medical data and the computing power to process it from womb to tomb, even to prevent an illness before it happens." Now, for the moment, I want you to just entertain that scenario. What happens to medicine when the patient has access to as much information as the physician?
Well, I can tell you that with the advent of the internet, in a way that's already happened, and it hasn't necessarily worked out for the best for both patients and physicians. You can find just an enormous amount of information on any condition on the web, but it's of varying quality. Yeah. During my time as a practitioner of maternal fetal medicine in New York, when I was doing consultations in high-risk obstetrics, this is even back in the mid-90s, it wouldn't be unusual for a patient to come in for a consultation with a stack of papers that were, 5 or 6 inches thick on the research that they've done. I believe in transparency of both data and information. Part of what we learn as physicians, though, is how to assimilate that information and then put the pieces together sort of like a detective and apply it in the right way. That's the thing that's missing in the non-physician world with access to that data. Everything seems like it's likely when you don't have the educational context to put it together. And really, that's the direction that medical training is headed anyway. We're getting to the point now, just with the explosion of the medical literature and genomics, medical knowledge is doubling every 70 to 90 days. So a lot of it is not about, from a physician standpoint, what you know at this given moment. It's a lot about what you can actually learn in real time and put together and apply to the patient. So a lot of times, I think that information that patients come in with, especially when they find it in forums, sometimes the patient comes up with the right diagnosis, but doesn't necessarily understand the severity of the treatment. So It's the physician's responsibility over time to act more as a librarian or a curator and navigate people through the information that they've picked up on their own. The other thing is, while many common conditions have great evidence-based approaches to them that are somewhat formulaic, I'd love to say medicine was truly a science. There's a large detective-like quality to being a good doc. And eventually, I'm sure artificial intelligence tools like Watson will closely approximate what we can do. But I think there's still always going to be the need and the requirement of physicians to make sure that the technology is giving a real-world logical answer, because it can still go somewhat awry. So I think, again, our function as physicians is going to increasingly morph into providing direction, providing education and translation for what the layperson finds, and helping people make decisions. Now, what a doctor should be doing, and I think in most cases are doing, is meeting with patients, finding out what they know, helping them make informed choices about what's best for their healthcare. That's what the physician of the new millennium really is all about.
Dr. Funai, I want to thank you very much. We found that Innovators gives us a chance to learn much more than we ever could imagine. And this has been one of those days. So I want to thank you very, very much for your insights. Thank you very much for your time. I hope we can convince you in the future to come back and talk to us some more.
It would be my pleasure. This has been a whole lot of fun to talk with you.
Thank you.
Thank you for listening to Innovators, a production of Harris Search Associates. We'll have more insightful conversations with global thought leaders to follow.